else they can affect the...
They can dilute the sodium level, right? Is it actually lowering the sodium? No. Is it going to cause symptoms? No. You'll get symptoms of too much glucose, right? That causes some, that's going to cause some 3Ps and other problems. You'll get symptoms of hypertriglyceridemia with pancreatitis, but is it going to cause sodium symptoms of being altered and seizing? Absolutely not, right? It's just dilutional. So you can actually figure out what someone's actual sodium is based on the corrected sodium. So just Google corrected sodium, and when someone's glucose is high, not when someone's triglycerides is high. You can't. There's no formula for that, right? But you take the sodium. So let's say the sodium is 126. You're like, oh shoot, sodium's low, right? And the sugar is 1,000, right? So sugar is 1,000, and the sodium is Let's just make it easy, 125, right? So 125 plus 2.4 times the glucose level-ish, right? So it's for every 100 points beyond the first, because if it's 100, that's 100 minus 100, 0, that's 0. So if it's 100, glucose is 100, my sodium is 125, that's sodium is 125. But my sugar is 1,000, that's for every 100, that's 9 100s, right? If the sugar is 1,000. So it's 125 plus 9, 134. Sorry, I did that wrong. It says 120, it's 2.4 times, right? So and usually there's some formula where like with 1.6 or 2.2 or 2.4, you could do 2-ish, right? So 2 points for every 100-point elevation. 1,000 is pretty significant, right? So 9 times 2 is 18. 125 plus 18 is actually 143. So that patient is not hyponatremic at all, right? So 1,000 is pretty ridiculous. So probably like 600, 500, 400. All right, if you have 500, that's 4 times 2, right? So at 8 points, so 125 to 133, it's not as bad as 125. So serum osmo is usually normal in pseudo-hyponatremia. So that's another key feature that you might not have a dilution, or a pseudo-hyponatremia. Because if you say dilutional, that's different. That's more like euvolemia. All right, that's a euvolemic hyponatremia. And thyroid, here it comes again. Right, you want to get thyroid level because thyroid itself inhibits ADH, and if it's inhibiting ADH, that's going to cause hypernatremia. But if I have low T3, T4, right, that means I've lost the inhibition of ADH. Therefore, ADH is increased, and ADH is increased. It's going to do its thing. What does ADH do? It holds on to water, right? Plasma changes, blood volume changes. That's going to trigger ADH, and ADH can go to the kidneys, and it's going to absorb water from the kidneys and put it back in the bloodstream, diluting out my serum sodium. Okay, and cortisol we talked about as well. All right, aldosterone absorbs sodium and water, and we're going to lose the aldosterone, which is going to restore blood volume. If I don't have blood volume, that's low blood volume. Low blood volume. Over here, sorry, low blood volume, right? Low blood, there it is, a little sad face. All right, low blood volume leads to ADH release, and that's what happens with low aldosterone levels. I got low blood volume. All right, so those are important things to get ordered. They get a ADH, there is such thing as a copeptin ADH, but you can't really get an ADH level technically. All right, but you can get thyroid levels, you can get sodium levels, you can get glucose, triglyceride levels, you can get all those other things to figure out why is someone hyponatremic. All right, other things we can look at are urine studies, right? So if the urine is very, very dilute, right? That means that we're losing water in the urine, right? But if the urine's super, super concentrated, that means my body's holding on to water. And we just talked about ADH. ADH holds on to water. So if I have increased ADH, right? So I have here like SIADH, right? Where are we at here? Right? SIADH, I'm going to have a really, really high serum osmolarity, right? What's the urine sodium going to be? The urine sodium is also going to be high because aldosterone only gets released when the blood volume is low. So the blood volume is high because, is increased, right? Because of ADH, or have increased water content. That's going to cause my aldosterone to not fire off, and therefore it's not going to do its job of holding on to sodium in the tubules. It's going to lose the sodium into the urine. Okay, so going back to urine studies, so if it's concentrated, that's most commonly due to increased ADH. All right, the kidneys are responding to it and doing their job, right? So if they have SIADH, it's going to do its job really well. If we have dilute urine, though, right, that means the kidneys are secreting free water for some reason, right? So they have more water than solute intake. So they have a tea and toast diet. They have beer potomania, right? They are weeing for the wee. They have more water than solute intake. If I have more water volume, right, more volume in my bloodstream, that's going to inhibit or stimulate ADH. What is more water volume going to do? That's going to, ADH responds to low volume. So if I have more volume, I have no ADH. If I have no ADH, I have no antidiuresis. Therefore, I have diuresis, right? I have water loss, right? So I'm going to have a low urine osmolarity. The urine concentration is going to be very dilute because ADH wasn't working, right? Because I did it to myself. I increased my volume intake. Okay. So what else? So urine sodium is another test we can do to see if aldosterone is at fault, right? Because if aldosterone is working, what do I expect my urine sodium to be? If aldosterone firing off, it's absorbing sodium, exchanging potassium, right? Dumping potassium in the urine and taking sodium out of the urine and putting it back in my bloodstream. So I'm going to have a what? I'm going to have, yeah, hopefully my sodium goes up, but we have hyponatremia happening. But I can look at the urine studies and see, oh, look, the urine sodium is low. That means aldosterone is doing something. Right? Aldosterone is happening. There's increased RAAS activity, such as like with CHF or cirrhosis. There's increased RAAS activity, and the urine sodium in these edematous states is going to be where? Low. Why is the urine sodium low? Because aldosterone is there. Aldosterone is absorbing all the sodium taken out of the urine, putting it back in the serum. Okay. When it's high, when the urine sodium is high, all right, that means that aldosterone is not working, such as like SIADH. Increased volume is going to inhibit the RAAS system, inhibit aldosterone release. Okay. All right, and then sometimes this is not purposeful, but a isotonic fluid challenge gets done on patients, unfortunately. So it should not happen, but it happens because everybody gets like normal saline in the emergency room. They get 1 to 2 liters normal saline. That's going to mess up all our studies. It's going to mess up our urine sodium, all the other things. So we have to keep tabs on it, because if someone has SIADH, that's the worst case scenario if someone has hyponatremia, right? That's going to cause a lot of problems if I give normal saline to someone. Because if I give normal saline to someone with SIADH, that's increased volume. If I have increased volume, that's going to inhibit aldosterone. Therefore, aldosterone is going to pee out more sodium. So basically, you just created a desalination plant in your kidneys. You gave them normal saline, and all it did was put the sodium back in the sea, back in the urine, and it held on to water because ADH is going to do it as inappropriately being secreted. Okay, so that's the idea with these tests. We look at urine sodium, urine osm, look at serum studies to figure out the cause, and we can see what happened when they gave that liter bag of saline or 2 liter bag. All right, so hyponatremia algorithms. So there's all kinds of algorithms out there about like do this, do that, but they don't really tell you as much information as just getting a history. Oh, you only drink beer, or you drink that much water, you drink out of your dog bowl. Tell me more about that. Do you have any history, any psychiatric history, right? So looking at the history is one of the key reasons to tell what someone's hyponatremia might be, right? Like, oh, you're on diuretics and you still drink water. That's a what? That's a hypovolemic hyponatremia. Okay, so you got low sodium. You got to make sure it's not something weird with endocrine, and look at their fluid balance. They got a lot of fluid intake. That's able to take it. That might be the reason why they're hyponatremic. They got cirrhosis or CHF. That's because of ADH and aldosterone absorbing 2 waters and 1 sodium at the end of the day, right, making them dilute. And then they got vomiting, diarrhea, but they have access to water. That is someone who didn't take someone's advice to drink Gatorade in the desert. They drank water in the desert, right? They lost sodium out of their sweat, and they only replaced water. And then medications. We mentioned many medications can mimic SIADH, such as some psych meds are high risk for causing a SIADH situation, right? So the idea is to look at the urine values, right? Look at the urine sodium, urine osm. Look to see if there's dilution happening with pseudo-hyponatremia, which we talk about glucose can cause a dilution of our serum sodium. Okay, and looking at aldosterone function versus ADH function can clue us into what the cause might be and what we need to do to fix it. So how do you fix it? So to fix a low sodium, you only fix it when you have symptoms, right? What are the symptoms of low sodium? They have seizures. They are getting altered, right? Headache, nausea, vomiting, dizzy could be explained by other things, but if they definitely are more confused than they were at baseline, that is a symptomatic patient, a symptomatic hyponatremia. So the first step for all these guys is to decrease water intake, right? So if you decrease water intake, that's going to, hopefully, are going to stop the release of excessive ADH, right? That should, make our serum more concentrated if we stop drinking water and inhibit ADH release, right? If we give saline to a patient that has SIADH, though, we know that's going to desalinate. That's going to make their serum sodium much, much worse, right? That's usually classic because someone with SIADH, they gave them 2 liters of saline, and the sodium went from 126 to 116. That's a dramatic drop in the sodium because the body did what it's supposed to do. It responded to this extra volume by inhibiting the RAAS function. Okay, so do not give isotonic fluids unless we know for sure, but decrease the water intake is a good approach. But if they are symptomatic, they start having seizures on us, then the next steps are to give hypertonic saline in some fashion, right? So you can request hypertonic saline, you order it into the computer, it goes down to pharmacy, they're on a coffee break, and they come back, oh, they need stat hypertonic saline, eh? Let me mix that for you. It takes them 10 minutes to mix it, and then the pharmacy tech's on lunch, he comes back, and then he runs it up to your room, and then the patient has been seizing the whole time. How long was that, right? On a good day, it could take 10 to 20 minutes. Or we can go to the crouch cart and do what, right? Just grab 2 amps of bicarb. We know that bicarb is extremely hypertonic, has a lot of sodium in it. You give 2 amps, that's going to raise your sodium about 3 points, right then and there, right? So 2 amps of bicarb is equivalent to about 6% saline. If you are to give 3% saline, it's going to be given as a bolus, 150 ml bolus, not a drip over 24 hours. That's not the way to give it if someone's actually seizing right now. If someone sees, okay, I'm going to start this at 35 mLs an hour, so in 1 hour to get to the 5 cc's, we'll get that fixed about 15 minutes, right? So that's not the right option. The option is to bolus the 3%, or we can give 6% just right then and there with 2 bicarb pushes, right? This happened about a month ago where he had a patient in the ER with subarachnoid hemorrhage, and his sodium would come out to be like 118, and we're like, he's seizing. Let's give some. Let's fix that, right? It's probably the hyponatremia or even the bleed, but either way, let's give 2 ounces of bicarb. That's going to fix the seizing right now. Okay. So it's quickly available in the crash cart for immediate use for a declining neuro patient, whether it be an ICP patient, because ICP patients seize also, right? Like in this example. So that patient can also benefit from 2 ounces of bicarb, okay, if they're actively seizing with cerebral edema. All right, so then hypertonic saline or hypertonic bicarb, whatever you got to do to get their sodium up immediately, right? And it's going to raise your sodium by about 3 points when you give this hypertonic saline, okay? So we did all our labs, we did all the things. If they're symptomatic, that's where you absolutely have to get treatment immediately, whether it be a bolus of 3% or it be a 2 ounces of bicarb. And then we got to look at the labs. Again, are the labs going the right direction, right? We should see a 3 to 5 point increase, and if we don't, if it's less than 4, we should maybe repeat the therapy again, right? And they have a persistent hypovolemia hyponatremia that we need to get fixed. We're not going to overdo it. We'll talk about overdoing it in the next slide, but we are going to make sure that we are getting that sodium corrected, right? If they're still symptomatic, right, you gave the 2 ounces of bicarb and the sodium goes from like 118 to let's say 124, like 6 points, that wasn't hyponatremia causing the seizures. That was something else. Maybe they didn't take their seizure meds, or they're altered because of an overdose of some sort, right? So that's a clue that they don't have a hyponatremia situation. They have a maybe something organic. A CT needs to be done to figure out what the underlying cause of their seizures is. All right, so sodium correction. How do you fix sodium? We're going to raise it acutely if they are super sick, but if they have symptoms, and where sodium is like less than 110, sodium is less than 120, and they're getting like mild symptoms, what can we do? Right? How much sodium should it be risen by? Right? So that goal sodium is about 6 to 8 MEQs per 24 hours. We mentioned if we have it more than that, they're at risk for what complication? CPM, or central Pontine myelinolysis. Osmotic demyelination will occur if we overdo it. We correct their sodium greater than 8 MEQs per 24 hours. Now that includes the 3 to 5 points that we're doing with our emergent treatment, right? So that's included. So they are actively seizing. The sodium is 102, and we rose it to 106 because they had that seizure from the hyponatremia. How much can we raise it by 24 hours tomorrow? What will it be from 102 to, or 106 to? So which one is it? Because it's included, right? What we did to correct that sodium immediately is included in how much we should correct it in 24 hours. So that's 6 to 8 points in 24 hours. So 102 to 108 to 110. So we want to be at 108 to 110 by 24 hours from now. What if we go to 112? Oh, I guess that's it. I guess we messed up. Oh, okay. All right, but that's not the case, right? The CPM is a very, very unique process in that you can mess up grossly. You can go from 108 to 138. As long as you get it down to 108 to 110 in 24 hours, that's your goal. Then you are not going to get at risk for this disease process, this complication. It's very, very unique, right? Usually like blood pressures, it's like, oh, as long as you get a blood pressure of 160, but if you all go up to 280 blood pressure, all the way up to 70 blood pressure, and then by 24 hours, oh, I'm 180, look at me, right? You're going to have a lot of complications, right? But with sodium, you can overshoot it. So it's looking at the net change. So the net correction. So our goal is 8 to 10 points within 24 hours, right? So obviously we should be checking sodium every 2 to 4 hours to make sure that we're getting to that target, right? We don't want to overshoot it. We don't want to undershoot it because then we didn't do a good job. So we got to make sure that we are hitting that 8 to 10 point, or sorry, 6, I say 10, 108 to 110, but 106, we want to get a 6 to 8 increase in our sodium level. Okay, does that make sense? So we want to get the sodium corrected within 24 hours. So it's the net change. So how do we do that? So if they do overcorrect, they get central Pontine myelinolysis. It also does not rear its ugly head until 2 to 3 days later. So he's like, oh, it's 114, we're good, there's no symptoms, they're perfectly fine, there's no reason to worry about it. But come to find out, they're going to have permanent neurologic deficits if you did not correct it within that 24 hours. So it's a serious situation. We always got to make sure they are within that goal. Okay? And we talked about the ones that are high risk for this happening to. Right? So who else is at risk for this happening to? Those who get potassium. What happens with potassium elevation? When we raise potassium, what happens to the sodium? Goes down, right? So raising potassium is a positive ion, and you have to move another positive ion back into the cells, and that ion is sodium, right? So sometimes patients do present with hypokalemia and hyponatremia. So they're a high risk of if they're for CPM because we're just 108 to 110, or sorry, I keep saying that's our example. We want 6 to 8 points elevation in 24 hours. Okay, so how do we achieve that? We achieve that with what's called a DDAVP clamp. So we give ADH. Well, I thought SIADH caused hyponatremia. Why would I give ADH? So it's going to it's going to shut off any kind of urine output, and it's going to gradually raise our what? Is it going to raise the sodium or lower the sodium if I apply ADH? Nope, ADH is going to lower the sodium, right? So DAVP is given for overcorrection, right? So sodium, in our example, from 102 to 112, we want to get it back down to 110. You want to keep it there. We're going to clamp them down. We're going to make sure that the sodium goes down to the range I want, right? But what if we check it in 4 hours, the sodium is 106? Do I still keep giving the DDAVP? No, we're going to then remove the DDAVP and allow the sodium to go up a little bit. We may even give 3% while they're on the DDAVP. So it's a measured way to bring the sodium up to where we need to. So if you're on ADH and 3% saline infusion, like 35 mLs an hour or so, because they're low rates, you should never see a 3% that's like 100 cc's an hour. That's really crazy, right? But if you have this 3% saline going with DDAVP, it's going to slowly bring my sodium up to where I want it to be. Right, it's going to be, we're in full control. But if the sodium is now going to like 112, 114, it's like, well, shoot, let's discontinue the 3%. And I may give D5 water, because what does D5 water do? It's going to dilute out the serum, right? And if I have DDAVP, It's to dilute out the serum exactly where I want it to be. So that's what we're doing. We're doing serum sodium levels every 2 to 4 hours, and we're applying DDAVP, 3% D5 water, and you're going to go nuts when the neurology and not neurology, but nephrology and intensivists are going back and forth. Like, okay, add DDAVP. Oh, let's add 3%. Let's do 3% and DDAVP. Hey, let's add D5 water and 3% and DDAVP. You're like, what the heck are we doing, right? Are we going up or down? What's our goal? But it should make sense, right? ADH is going to do what? It's going to lower my sodium. 3% is going to raise my sodium. D5 water is going to lower my sodium, right? So these are all goals because in 24 hours, we got to keep it at what? 6 to 8 points from where it was previously. That's every 24 hours. So in 24 hours, I'm at 110. My goal is to get 6 to 8 points, 160 to 180. And then from then, it's 122 to 124, right? You want to get all the way up there, nice and slow, right? Usually once we're over 120, you're done. You don't need to keep playing around with this anymore. You can let them know, hey, this is super crazy. Can we please stop, right? And then what's next? So that's acute hyponatremia or really, really severe hyponatremia with like chronic with like sodium less than 110, sodium less than 105, someone who has symptoms, right? We corrected it immediately with hypertonic saline. And then after that, we brought up the sodium slowly as tolerated, right? Within a goal of 6 to 8 points within 24 hours. Now, if your sodium is 122, they have no symptoms, and it's chronic because they have CHF or cirrhosis, you're not going to get a Nobel Prize, right? You're going to have doctors out there or providers out there that are saying, you know what, sodium's 122. Are they, let's start 3% saline. It's like, what do we're not gonna, what are you doing? Why are you correcting their sodium in this situation? That's not the purpose of hyponatremia. Hyponatremia is when they're symptomatic, and they're severe enough. Okay, so the treatment again, SIADH, the goal is to pull out the excess water only, and we can give what's called urea, and that makes sense, right? Because what does ADH do? It pulls urea from the urine and pumps it back into the bloodstream, and that will then cause a rise in our volume, right? And dilute us out. So if we give someone urea, it's going to pull water right back into the urine, right? So actually giving urea to this patient will pull down the free water and hopefully raise our sodium. They may need to get 3% saline or Lasix to get rid of the excess water. There's such thing as ADH blockers, anti-ADHs, or Vaptans, and they're extremely unpredictable, and they're not recommended as a medication, but you may see them being given. What's more appropriate in the ICU is 3% DDAVP going back and forth to get their sodium under control. Remember, heart failure and cirrhosis, these guys are chronic. You're not going to win a Nobel Prize for fixing their sodium unless it's like less than 110, unless it's causing symptoms. Then that's where we would then try to get rid of the free water. And usually they're already getting furosemide or some kind of diuretic combination to get rid of water. Same thing with their cirrhotic patients. They're usually getting furosemide and spironolactone being number one, right, as the agents to get rid of this excess water and hopefully correcting someone's hyponatremia. And then hypokalemia. As we mentioned with hypokalemia, right, that's going to cause what change in our sodium? It's going to make our sodium go up, right? So increased potassium leads to increased sodium. So it's a good idea to not, be very, very careful for replacing potassium also. We're going to make sure that we're doing a full chemistry, every 4 hours, every 2 hours even, to make sure that we have a good change within 24 hours, right? And sometimes they might have to be adding things back on, adding the 3% and DDAVP clamp to get their sodium to 6 to 8 MEQs in 24 hours.